Kia ora. My name is Clinton Lewis. I'm a haematologist in Auckland, New Zealand, and it's my pleasure to present our poster on the epidemiology of acute promyelocytic leukemia, APML, in Aotearoa, New Zealand, on behalf of my collaborators Dr. Alana Cavadino and Dr. Henry Chan. APML is one of those key subtypes of acute myeloid leukemia, which is characterized by its classic morphology, its distinct presentation, often with a bleeding phenotype, as well as its excellent disease outcomes. It's characterized by the classic fusion gene, often caused by the translocation of chromosomes 15 and 17, and has an incidence reported in the literature of between 0.2 to 0.4 per 100,000 people. The purpose of our project, as part of a larger project looking at AML in New Zealand, was to describe the incidence and outcomes of patients with APML in Aotearoa, New Zealand, using the Cancer Registry database. The method that we followed was to extract cases of acute myeloid leukemia from the New Zealand Cancer Registry as part of a larger project. We used the ICD-10 codes to identify all appropriate AML type coding and looked at the time period from 1997 to 2019. We identified 3,892 cases and excluded the vast majority of them because they did not meet the diagnosis of APML. We used the diagnostic code of C92.0 to identify cases of APML, and then cross-referenced this with a national data register for death, as well as a prescribing data set which is available. Now, of note, the data sets didn't overlap perfectly, but were able to provide us with some important information which added depth and richness to our analysis. We used standard statistical methods, including the Kaplan-Meier method for calculating survival probabilities. The results, which were quite interesting, were that we identified 209 cases of APML. Only one of those was reallocated to the APML category after considering the prescribing information, so the initial stratification was very good within the Cancer Registry. There was a small population, about 11% of patients that were above the age of 70, and a very slight male preponderance, with 47.9% of patients being female. The ethnicity breakdown largely reflected the New Zealand population, and incidence was likewise within the realm of what would be expected based on the literature at 0.28 cases on average per 100,000 population. The most interesting data is in the Kaplan-Meier curves here on the second column. At the top we have the survival for the complete cohort, which shows the 30-day survival at 88.5%. And again, this survival remains very outstanding, out even to the 5-year mark. We did a landmark analysis from day 30, so all survivors that survived to day 30. There was a very slight drop-off over the next 5 years, but really those survivors tended to do very well. When we started to look at an important cohort of interest, which was the older population, we found some very different results, however. Now, there wasn't an enormous number of patients in our analysis that were in this older age group, but when we looked at them, there was a marked drop-off in survival. That those patients 70 and above had a much higher mortality, particularly in the first month in particular, but that stretched out to the 6-month mark. So that the median overall survival for patients above the age of 70 was only actually 6 months, compared to a median not met for the overall cohort or for the younger population. So in conclusion, outcomes for patients with APML in Aotearoa are consistent with international reports in the literature, and the population of patients getting APML is largely consistent with the New Zealand population makeup. There is a significant mortality seen, particularly in elderly patients, in the first month or two of diagnosis, and this really does represent an important area of unmet need and an important area to focus further research on. Finally, early identification and treatment remains important for all patients with APML, reflected in that approximately 12% mortality in the first month. This is often because of the bleeding diathesis associated with this disease, and it's crucial that early implementation of all-trans retinoic acid, or ATRA, is implemented. And we did see this when we looked at the prescribing data. I'd like to thank you for your attention today, and I'm happy to answer any questions. If you'd like to contact me, we can discuss further offline. Enjoy the rest of your conference.